Ian, can you tell us a little bit more about the treatment options for this patient?
Yeah, so, I think fortunately for HER2 positive disease, we now have a number of large trials that give us, I think, a lot of confidence that we're treating these patients optimally. Back, as far as 2005, we had large adjuvant trials demonstrating the benefit of HER2-directed therapy with trastuzumab for those patients, and that became the standard. We next had the APHINITY trial, which sought to build on the trastuzumab data by assessing the role of pertuzumab in the adjuvant setting. This was a study that looked at largely HER2 positive higher risk patients and randomized them to a number of different chemotherapy regimens with trastuzumab, with pertuzumab, or with placebo. And that study initially reported a statistically significant but really modest benefit overall of adding pertuzumab to chemotherapy and trastuzumab. I think we're better off now that we have updated data that were reported at San Antonio in 2019 with now 6 years of follow-up, which confirmed, again, a statistically significant overall benefit, but helped us really distinguish who are the people who benefit, at least at this time point. And that is that essentially all of the benefit, at least so far, have been in node-positive patients. So here, the absolute difference in IDFS, or invasive disease-free survival, was 4.5%. So now we're talking, what I think everybody would agree is a meaningful benefit, and really no benefit so far in the node-negative patients. And the benefit was irrespective of hormone receptor status. It seemed pretty equal for both hormone receptor positive and hormone receptor negative HER2 positive patients. Survival has also been looked at. It's in the right direction, favoring pertuzumab, but not statistically significant, but these data are still immature. Adding pertuzumab does come at a cost in terms of toxicity, as well as financial. And the major toxicity increase with pertuzumab is diarrhea, as we heard from the patient I presented. The overall risk is not that high. It's about 10% of grade 3 or higher diarrhea, compared to about 4% without pertuzumab. And essentially all of that grade 3 toxicity is while the patients are getting chemotherapy. At least in my experience, for most patients, it's manageable with antidiarrheals like Imodium, but there are a few cases in whom it really becomes a problem. And in those patients, I think it probably makes sense to stop the pertuzumab rather than compromise their chemotherapy during treatment. We also, you may remember, have data using the very potent tyrosine kinase inhibitor called neratinib. This was a study that actually looked at patients who'd already had a year of adjuvant trastuzumab and randomized them to either a year of this oral TKI neratinib or a year of placebo. And that study did show a statistically significant and probably clinically meaningful benefit with the addition of neratinib, but it was only in the hormone receptor positive, HER2 positive patients, and it came at a real cost of toxicity with a substantial amount of grade 3 or 4 diarrhea, almost 40%. There have been studies showing that can be mitigated to some extent with upfront prophylaxis with antidiarrheals, but it's still something that has to be kept in mind. So we have these two adjuvant trials looking at pertuzumab and neratinib, but I think the real game changer came with the KATHERINE trial, which looked at patients who had had neoadjuvant HER2-directed therapy and chemotherapy and did not have a pathological complete response. These are patients who had residual disease after neoadjuvant therapy. And we've all known for some time, based on a number of studies, that patients who don't achieve a pathological complete response do have a higher risk of recurrence compared to those who do have a path CR. But I think what was important about KATHERINE is that it asked this question of, can you do something about that inferior outcome by adding a different therapy. And so it randomized these patients to TDM1 for 14 cycles or standard trastuzumab for 14 cycles, and showed unequivocally that the use of TDM1 was associated with a substantial improvement in invasive disease-free survival, hazard ratio of 0.5, and an absolute difference in 3-year IDFS of 11%. So really a sizable difference. It was seen across all of the usual subgroups, and the benefit was even seen in patients with pretty minimal residual disease. So I think based on those data, it's pretty clear that we should be treating all of our moderate to higher risk HER2 positive patients with neoadjuvant therapy, because without that neoadjuvant approach, you can't determine who's going to have a PASS-CR and who doesn't, and therefore who would benefit from adjuvant TDM1. So I think that data set from KATHERINE really led to this guidelines that are now out from a number of groups that all patients with stage 2 or 3 HER2 positive disease should receive neoadjuvant HER2 directed therapy, and that's what informed our decision for the patient that I just presented.
So this is great. I really appreciate that excellent summary about our current options for treatment. I think, you know, it's really interesting how much we've learned in an area that we thought we'd learned most already in the last year, really, 2 years.